All right, class, we're going to talk about some of the complications that we unfortunately see with diabetes, and these are probably some of the main reasons why your patients will become patients in the hospital, why they're going to be admitted. Three of the most serious type of diabetic emergencies are diabetic ketoacidosis, which we're going to talk about later on, along with hyperglycemic hyperosmolar state, HHS. DKA is a lack of insulin and a severe state of ketosis, and your HHS is caused by insulin deficiency and profound dehydration. And also we have to think about the patient who becomes extremely hypoglycemic from either too much insulin or too little glucose. And very often we see this problem occur while our patients are in an acute care setting, where they're known diabetics. Obviously being in a hospital with a illness is a stressful time for the body, and many times it's very hard to adjust their medications if they've been known diabetics and have been on either oral hypoglycemics or even insulin. That many times we see them run into problems with hypoglycemia, and we cannot take that situation very lightly. Remember, people with hypoglycemia, they can die from that, and that's why when we know that our assigned patients are diabetics, we should always be aware of the hospital protocol of what we're going to do for these patients if their blood glucose gets too low or if their blood glucose gets too high, because we have kind of standard orders where we can start initiating interventions to hopefully get that blood sugar in a more safer range, because hypoglycemia can be a very dangerous situation. So some of the chronic complications of diabetes really involves the macrovascular and the microvascular disease, and all that is just a fancy term for saying that diabetes in fact affects the tiny little blood vessels that supply blood, nutrients, oxygen to the smaller types of organs, such as the kidneys and of course the eyes. And then we talk about the macro, which are the big blood vessels, for instance, that are in the heart, that supply blood and nutrients and oxygen to that particular organ. Many times over the years, that's why it's very important to understand your patient's own sense of how he portrays his diabetes, because you kind of want to figure. And we see a lot of these vascular problems involve the vision or the eyes, retinopathy, problems that involve the kidneys, nephropathy, and of course nerve dysfunction called neuropathy. And that's probably one that we're most familiar with because we talk about diabetic neuropathy. There's a lot of theories of why this process happens. Irreversible basement membrane thickening and organ damage, glucose toxicity that directly or indirectly affects the function of the cell integrity, chronic ischemia in the small blood vessels can cause connective tissue hypoxia, and microischemia. And referring to all those areas where these complications occur, they've kind of labeled it what we call a diabetic triopathy, regarding the microvascular, retinopathy, nephropathy, and neuropathy. Okay, and really I think the bottom line is when a patient has chronic conditions of hyperglycemia, and we're probably talking about somebody who really doesn't have a good understanding of their diabetes, who doesn't really control it very well, that hyperglycemia leads to neuropathies through blood vessel changes that really basically the bottom line is it causes nerve hypoxia. And remember, if you think about the anatomy and physiology of that myelin sheath, the axon and its myelin sheath are damaged by decreased blood flow, resulting in blocked nerve impulses. Okay. Blocked nerve impulse transmissions. So we'll talk about each of these a little bit more specifically now in regards to these chronic complications. Macrovascular, we've kind of touched upon this when we've talked about cardiovascular disease, how we see these patients who are diabetics are probably at increasingly higher risk for acquiring cardiovascular disease. In cardiovascular disease with diabetes is definitely the most common complication, okay? And with this, we can pretty much guarantee that somebody who has diabetes will have a reduced lifespan, especially if they do develop cardiovascular disease. These patients die because of a thrombotic event, usually an MI, and diabetes will eventually affect the actual heart muscle. They develop systolic and diastolic heart failure, and of course along with that comes fatal arrhythmias, left ventricular dysfunction, and even all these things can increasingly occur after an MI, okay? Even your pre-diabetics who develop metabolic syndrome are at risk for cardiovascular disease. Women are at greater risk, and definitely that's influenced by their ethnicity, okay? Obesity, increased blood pressure, dyslipidemia, and sedentary lifestyles, along with cigarettes and their genetics, will definitely predispose these people to developing macro complications, cardiovascular disease, along with being diagnosed as a diabetic. Remember that lab value, CRP, C-reactive proteins, that's more of that inflammatory marker, if you recall that from our cardiovascular lecture, and that will definitely be increased. This is why when we know someone is diabetic and maybe has some of the risk factors present, the healthcare provider will greatly be very aggressive with the management of things like their blood sugars by controlling their blood pressures, getting their cholesterols down, especially their HDLs up and their LDLs down, setting a little stricter parameter for their blood pressures as well as their LDLs. So this will hopefully slow down the progression of some of these serious cardiac events that could occur. And again, good teaching with diet control. Diets high in saturated fat raise total cholesterol and LDLs. So it would be important to teach them about low saturated fat diets, trans fats, and cholesterol levels. Really increasing their intake of omega-3 fatty acids, fiber, encouraging them to lose weight, increase their activity, and really modify some of their more kind of unhealthy lifestyle habits, such as smoking, their diet, and of course getting them to exercise more. Really getting them maybe possibly on a statin or even on aspirin therapy. Because with diabetes, it increases someone's stroke chances of 2 to 4 times more, along with even atherosclerosis of the carotid arteries, causing that stroke to occur, and then raising blood pressure, increased lipids, nephropathy, peripheral vascular diseases, along with people who are diabetics and drink a lot of alcohol, smoke a lot of cigarettes. That also helps increase the risk of stroke. And outcomes with a person who does have a stroke or a CVA in a diabetic patient are less favorable. If the blood sugar is high at the time of the stroke, mortality rates are much more increased. So that's kind of a quick summary of exactly what's on this PowerPoint slide. With diabetes, and macrovascular complications. Cardiomyopathies, abnormal blood clotting, and complications are much more fatal after an MI when someone is a diabetic. Okay. And of course, again, looking at renal disease, albuminuria, which means protein in the urine. I've already talked about higher levels of CRP, and really giving some much more stricter parameters with their blood pressure. Getting it below 130, and I think they've even changed that, you know, to even below 120, and getting those LDLs down to less than 100, and really some extensive dietary teaching along with that. And of course, cerebral vascular disease, as we've said a few times prior, really damages that arterial circulation and puts someone very at high risk for a stroke. Okay, and people that are diabetic are much more likely to develop atherosclerosis and atherosclerotic plaques in their macro and micro vessels. Okay, that's why if these patients do develop that metabolic syndrome, you know, that puts them at risk for developing type 2 diabetes, we really want to look closely at their cholesterol levels, looking at LDLs and HDLs, and even triglyceride levels precisely. LDLs should be less than 130, but with diabetics we like it less than 100, and HDLs at least 45, and for men at least 55. And triglycerides should be less than 200. Okay. Some of our patients might have some very serious issues with hyperlipidemia, and that would cause them to really be a super high risk for microvascular changes. So when we talk about now looking at the microvascular complications, where we look at eye and vision complications, 25 times more common with patients who are diabetic, depends on the duration of diabetes as to their degree of retinopathy. Okay, so that's why it's really important that we as nurses kind of get an idea of how long our patients have been diabetics, because you can kind of get a feel when you start passing medications with them, how much they understand their medications, and when they don't really understand their medications, then it's pretty kind of understood that these patients probably have not had a good sense of what diabetes is about and have not really been controlling their blood glucoses very well. When we talk about these eye problems, we look at two very serious complications. Okay, we look at non-proliferative diabetic retinopathy, and kind of look at what that means is. And if you go back to when we talk about proliferation of white blood cells with leukemia, that's kind of the same principle behind non-proliferative diabetic retinopathy, or NPDR. What this is basically is a structural problem in the retinal vessels, okay, and retinal circulation, where the person will start to have a lot of edema, hard fatty deposits in the eye, and even retinal hemorrhages. And what occur is more of microaneurysms in the small capillary walls, and they start to dilate just like a regular aneurysm would do. And with these dilatations in the retinal vessels that form throughout the eye, they start to leak fluid and blood into the retinal area, and the leakage causes retinal edema and hard exudates. So that's kind of the pathophysiology behind this NPDR. Other retinal problems that occur is retinal hemorrhage, optic nerve atrophy, which leads to hypoxia, and venous beating, and abnormal appearance of retinal veins, in which areas of swelling and constriction along a segment of the veins resemble what we call like links of sausage, and that occurs with retinal ischemia. Obviously, this is not a good thing to have, but this develops very, very slowly and rarely causes reduced vision to the point of blindness. So a person will not develop blindness with them, but they may have some very serious issues with their eyesight. And this is what it kind of looks like. You can see the heart exudates, and this would be if, you know, their eyes were dilated, and you could look at that, all these vessels within the eyes, okay? And you can see the cotton wool spots that kind of represent the ophthalmic changes that occur in this particular eye retinopathy, diabetic retinopathy of the eyes. Now the next one is proliferative. And what proliferative means, you've got new things growing, but again, it's growing a lot, but remember, these are not good vessels that are growing to kind of account for the poor circulation that is within the eyes, okay? So proliferative diabetic retinopathy is PDR, and what this is a growth of new retinal blood vessels, also known as neovascularization. And because it senses that there's poor circulation to the eyes, it stimulates the formation of new blood vessels in the eye. And these retinal cells secrete growth factors that stimulate this new growth. But these vessels are not good vessels. They're very thin, they're very fragile, they bleed easily, leading to eye hemorrhage and vision loss. Central vision may be impaired by macular edema, and you have increased blood vessel permeability and deposits of heart exudates at the center of the retina. Along with this, a person can also develop macular degeneration, corneal scarring, and changes in lens shape and clarity. So this is probably not the one to have if you had a choice between the two. Along with hyperglycemia, we talked about it before. Many of these patients, when their blood sugars are really up there and not really within a normal range, can develop blurred vision, even with eyeglasses. And when they develop hypoglycemia, that may cause double vision. And cataracts also occur at a younger age, along with open angle glaucoma. That's why when people have diabetes, it's very important that they see their ophthalmologist on a regular basis to determine if this eye disease is progressing much more rapidly, and things to implement to reduce or to slow down the progression of some of these complications of microvascular problems to the eye. So that's why, you know, this is another reason why it's so very important that these patients really control their blood glucose. And remember, many of these issues, these are slow to, you know, to develop. It's not that this is going to happen overnight. Someone's diagnosed as diabetes and, you know, a week later they have PDR. It doesn't work that way. These happen over time because it starts to affect the integrity of the blood vessels. Some of the things that can be done for some of these eye diseases that I've just talked about, some of them that cause the hemorrhage out into the eye, to prevent further hemorrhage, they may do a panretinal photocoagulation laser where they actually put laser on some of the vessels and they actually shrink them, and it prevents that you know, bleeding out and that hemorrhage causing more edema and exudates to occur. Sometimes they actually, when they do bleed out, they can do what they call a vitrectomy, which removes blood and scar tissue. And removing that hemorrhage of that blood allows more light rays to focus on the retina and cause the person to be able to see somewhat better. Okay, so that's a little summary of some of the macro and micro complications, especially when we talk about the eyes. And remember, hypertension along with hyperglycemia increase the rate of some of these retinopathies occurring. Then I want to touch a little bit on diabetic neuropathy, which are progressive deterioration of nerves that result in loss of nerve function. Okay, and diabetic neuropathy, we think of it just in regards to maybe a person having tingling and burning in their feet, but it's much more than just that area involved. Diabetic neuropathy pretty much, sorry about that. Diabetic neuropathy often involves all parts of the body, okay? There's somewhat damage to the motor nerve fibers, results in muscle weakness, and then there can also be damage to the nerve fibers in the autonomic nervous system, causing dysfunction in almost every part of the body. So it's not only the nerve damage that occurs, but it's also damage to the motor nerve fibers, causing problems with movement, decreasing the use of that particular muscle. Metabolic factors of hyperglycemia, long duration of diabetes, hyperlipidemia, and low insulin levels kind of contribute to the progression of diabetic neuropathies. Damaged blood vessels leading to reduced neuronal oxygen and other nutrients, autoimmune neuronal inflammation, people who smoke and use a lot of alcohol, and hyperglycemia leads to neuropathies through blood vessel changes that cause that nerve hypoxia that I already talked about. Within the autonomic nervous system, there can be problems seen from diabetes in the cardiovascular system, the GI tract, and even in the urinary function. That's why it's so important that we keep blood glucose levels in the normal range, because they can actually slow the development and the progression of diabetic neuropathies. Some of these neuropathies can either be diffuse or focal, and the diffuse ones are more common, and what they are the involvement of widespread nerve function loss. Very slow onset to this, affects both sides of the body, involves motor and sensory nerves, progresses slowly, and are permanent. And some of the late complications can include foot ulcers and deformities, which we'll talk a little bit more in specifics later on down the road in some of these lectures. Your focal neuropathies can affect a single nerve or a nerve group, and are usually caused by an acute ischemic event or by nerve trapping. Both problems lead to nerve damage or nerve death, and you have a decreased blood supply to the nerves. Symptoms begin suddenly, affect only one side of the body area, and are quite self-limiting. All right. The most common neuropathies affect the nerves that control the eye muscles. Sometimes how these problems start and what symptoms start to occur is it may begin with a pain on one side of the face near the affected eye, and the eye muscles may become paralyzed, resulting in double vision. Sometimes these problems involved can last for months, okay? And then other problems that we may see is what we call anhidrosis, which means a lack of sweating, so the skin becomes very dry, cracking of the skin, and as you can see, that would lead to open areas on the skin, which can lead to infections and skin breakdown. Another thing that we see happen is entrapping, and that's compressing a nerve in the body compartment or between tissues. It can be bilateral, having a waxing and a waning course, and without a spontaneous recovery. An example of that would be someone who develops like a carpal tunnel syndrome. Now within the cardiac system, we see left ventricular dysfunction occur, exercise intolerance, painless MIs, orthostatic hypotension, even syncope where the person can actually lose consciousness for a brief time, and then also very prone to wrist falls. In the GI tract, we see gastric reflux, delayed gastric emptying and retention. Some of these people have diarrhea, as well as gastroparesis, where they have a delay in gastric emptying. Urinary retention. More people with diabetes are prone to UTIs, frequency, urgency, and incontinence. Periodontal disease, mood alterations, bladder and sexual functioning, and of course bladder impotence, bladder problems, and male impotence. Okay. So I just wanted to kind of go over neuropathies because I didn't want you to kind of think about it in a very limited way, that the neuropathies that occur from diabetes can affect every system and organ in the body. All right. And then we know, of course, about diabetic nephropathy, which reduces kidney function and leads to kidney dysfunction. Okay. And these are those pathological changes in the kidney that reduce kidney function and leads to kidney failure. Diabetes is the leading cause of end-stage kidney disease, and patients with kidney disease have a 10 to 15 year history of diabetes, diabetic retinopathy, poor blood glucose control, uncontrolled hypertension, and a genetic predisposition. Okay? And many of the studies that are done show that this may have been prevented if a person had better control of their diabetes and used drug therapy to protect the kidneys. And that would be such things as ACEs and ARBs. Remember, angiotensin, medications that block that process with the RA system, ACEs and ARBs. The earliest manifestation is microalbuminuria, where small amounts of albumin or protein are in the urine, and then over time we start to see that GFR, glomerular filtration rates, start to decline, and that's why with people with type 1, we recommend, if they've had diabetes for over 5 years, to really closely watch kidney function, and definitely with our type 2s as well. And many of these patients who have diabetes and develop kidney dysfunction, a lot of times with uncontrolled blood glucose, the blood glucose can cause hypertension, and increased pressure can also damage kidneys, and the vessels in the kidneys are leakier, especially in the glomerulus, and this then allows that filtration of larger particles, including these albumins or proteins, to pass through and be excreted in the urine. That's why we find it in the patient's urine, maybe through their urinalysis. Even the blood vessel, starts to change, becomes narrow, decreased kidney oxygenation, and leading to kidney cell hypoxia and cell damage. And then what happens over time, there's a scarring of the glomerulus, blood vessels, and loss of urine filtration. And if a person also has hypertension, this speeds up the process of kidney failure. And then, of course, the last note on this PowerPoint slide is male erectile dysfunction. At least half the men who have diabetes will experience erectile dysfunction. And this occurs 10 to 15 years earlier than the general population because these unfortunate people did not have good glucose control. They were obese, had hypertension, and probably were heavy smokers. This last one is just a picture of the proliferative diabetic retinopathy. You can see the pre-retinal vitreous hemorrhage. And what they do is they try to remove this blood and allow more light to get through, the optic nerve, so the vision will not be so impaired. And then, of course, we talk about the nephropathy, is destruction of the capillary of the nephron, gradual process evaluated by the GFR, very common cause of end-stage renal disease. And with renal failure, usually that's caused by about 43% of the population who have diabetes, 23% that have high blood pressure, 12.5% that have glomerulonephritis, 2.5% polycystic disease, and could be from other causes from 18 to 20%. This is just showing the stages of the progression of diabetic renal disease, stage 1, stage 2, and stage 3. You can see that microalbuminuria starts to occur in about stage 3, because that's about 7 to 15 years after a person has been diagnosed with diabetes and really has not really very well controlled their blood glucose. That's when you would start to see protein in the urine. And stage 4 is albuminuria, which you can detect by a chem stick or dipstick. And along with that, these patients probably have increased blood pressure that's not very well controlled. And then getting to stage 5, obviously GFR is going to be greatly reduced, which will affect renal function. These patients by this time will be on a dialysis machine. Teaching is a priority. 3/5 of the patients make errors in their insulin dosage. 2/3 of the patients don't even understand how to follow a diet, and 1/3 are managing their disease without any formal education. And 2/5, 2 out of 5 people do not regularly test their blood glucose, and that's a bad thing. Even when things are going well, their glucose should be tested at least 4 times a day. I know it takes time, but this will keep them aware of exactly where that blood glucose is to see if they need to make any adjustments with lifestyle, exercise, diet, or even their medications. So these are things that, really are very sad that this is what we're still seeing with our diabetic patients out there. And this is why we really need to do a better job into education with our patients who are diabetics. And obviously the amount of teaching that we do will be very dependent on age and how well our patients understand. And then later on follow-up to see that these patients are doing what they're supposed to be doing and that they're doing it correctly. These are some of the websites. These are things to definitely give our patients and the community this information. The American Diabetic Association, Juvenile Diabetes Foundation, especially for children who are diabetics, the Joslin Clinic at Harvard, and the American Association of Diabetic Educators. That may be something that you will want to be in your future. A lot of hospitals had educators on board that would go visit patients who were newly diagnosed, or even helping some of our diabetics who've been diabetics for a while, but a lot of cost cuts in the acute care setting have caused these diabetic educators to be kind of the positions eliminated, which is very sad, because I think they really did so much good and brought so much good teaching to these patients who really needed it. Because let's face it, anybody who's diagnosed with diabetes, it's a very, very stressful time, because this totally affects their life in every single situation. So I hope this last topic of chronic complications give you a little better insight of how serious this is when our patients do not really have a good understanding of how to keep their blood glucoses under control. And a lot of it can be through their own fault or just very, very poor teaching of how their medications work and how things in our everyday life do affect their blood glucose, especially their medications. That's why it's so important that they monitor their blood glucose 4 times a day, so we can maybe see a sense of the pattern of when we would see either hyper or hypoglycemia occur. Again, type 1 diabetes, this is just basically a review of what I talked about earlier, how type 1 is an autoimmune disorder in which the beta cells are destroyed. Exact cause unknown of person's own normal cells being attacked. And very often we see this type 1 diabetes occur after some type of a viral infection. Okay. Administration of insulin might result in honeymoon phenomena, which, initially, while they're healthy and there's no other stressors involved, they can be very well controlled. But after that honeymoon, when life starts to happen, they may need to have their medications adjusted or give them some additional teaching on how to keep those blood sugars in better control. And then, of course, we talked about metabolic syndrome along with type 2 diabetes, and we know what all those factors are. Please know these. Metabolic syndromes involves abdominal obesity, hyperglycemia, hypertension, and dyslipidemia. And dyslipidemia is the same thing as hyperlipidemia. HDLs are low, LDLs are higher. Remember, diabetes is the 7th leading cause of death in the United States, affecting 20.8 million people and 7% of the population. And since this book was written and since I provided these statistics, they've gone up in the last couple years. 90% of people with diabetes have type 2, and obviously health promotion and maintenance is a priority. Let's not even get those people to the point where they develop type 2 diabetes. Let's get out there and educate our communities and our publics so this horrible chronic disease can be decreased. I'm not sure we can either ever eliminate it, but hopefully we're getting closer and closer to a cure for diabetes. This is important to discuss with your patient as well as you as the nurse to understand signs and symptoms of hyperglycemia. Always tired, crave extra fluids, frequent urination, numbness and tingling of feet, always hungry, unexplained weight loss, blurred vision, and sexual dysfunction. Doesn't this kind of resemble some of the symptoms of the 3 Ps that we've already talked about? Very, very much correlated with those type of manifestations. And these are just the opposite. Symptoms of hypoglycemia: shaking, sweating, headache, anxiousness or irritability, dizziness, hunger, fast heartbeat, blurred vision, weakness, and fatigue. Not only you as the nurse should know these, but your patient should know these. And we'll get into more details because sometimes over time, as patients have diabetes longer and longer, they really do not recognize that they are experiencing hypoglycemia, and you don't want it to get to the point where a person is alone and becomes so hypoglycemic that they aren't aware to the point where they can't treat themselves. So that's why we want to have them recognize those early manifestations of hypoglycemia. And again, this is just a review of everything we've talked about, where hyperglycemia is really the inability to metabolize carbohydrates, because remember, we're not pulling that glucose into the cell for energy. Glycosuria is that filtered from blood and glucose that acts as an osmotic diuretic. Polyuria leads to hemoconcentration, dehydration, hyperosmolality of your serum. And then polyphagia, the cells are starving, mobilizes fats and proteins for breakdown and energy. And your polydipsia results as a manifestation of thirst because of the extreme dehydration that occurs. And of course, weight loss ketonuria filtered from the blood, resulting in a loss of water and sodium. Abdominal pain. A lot of these patients with metabolic acidosis develop GI problems. And then remember the Kuzma breathings. The respiratory system is trying to fix what has happened metabolically with metabolic acidosis in an attempt to bring those pH back to normal. Fruity breath with this Kuzma breathing, blowing off a lot of acetone, attempting to breathe off the ketones. And your neuroglycopenia is the loss of sensory. Penia, remember we talked about that with neutropenia, thrombocytopenia. That's when neurological function really starts to deteriorate and the person gets a little bit foggy and cloudy. And I've got, again, type 1 and type 2. Type 1, 100% of all these patients need insulin. Basically, insulin becomes these patients' lifeline. And with type 2, 20 to 30% diet and exercise. 50% will need oral hypoglycemics, and 20 to 30% will require insulin. Diabetes management is a constant juggling with medications, exercise, and diet. And this is just a case study that was in your, or a concept map, I'm sorry, that was in your book. Just kind of looking at all the parts and pieces to this. Sorry, I'm trying to bring down this slide so you can see it better. If you have time, it'd be nice if you, there we go, brought it down a little bit. It's a concept map for a type 2 diabetic, and I'd really like you to kind of go over that. If you can kind of see that, it's kind of hard to see this. You're much better able to go over this and review this from your book, but please, it kind of gives you a sense of what's happening metabolically and what kind of manifestations and pathology is occurring in your patient with type 2 diabetes. All right, I think we'll stop here and begin another topic regarding diabetes.